Director of Clinical Services in Neurology at the University of Health Network, the incoming Residency Program Director of the Adult Neurology Program at the University of Toronto, and a board member for the Alzheimer's Society of Toronto. Just a few things. So thank you very much.
Good afternoon. Thank you for the invitation, and I'd like to talk about something that is quite close to my heart and to my career, and it's neuroimaging of dementia. Can you all hear me quite well? So, and I think it should complement, I think Dr. Friedman's talk earlier this morning about some other non-Alzheimer types of dementia. This is an unusual talk because I'm not going to talk very much. You're going to actually do all the talking. So the first few things, some disclosures. I do have a couple of grants from the Alzheimer's Society and the Western Foundation. There's a big plug that this is not meant to replace a neuroradiologist. The neuroradiologists are very good friends of mine. They should be very good friends for you also. It's just to highlight some features that when reviewing individuals with dementia, there are certain key things that either neuroradiologists may not comment upon, but something you can actually direct them to look at. My objectives, you're going to learn how to read a CT and an MRI scan at the end of this hour. You're going to look at key neuroanatomical features on the CT or MRI, and you're going to know how they relate to various types of dementias. Why is this important? Why should we bother looking at CTs or MRs for the diagnosis of Alzheimer's disease? Well, we know that with the latest criteria, one of the key features nowadays is to look at the hippocampi, and with a high likelihood can probably diagnose them with Alzheimer's disease if the clinical picture fits. So I have a talk. There's a quiz. First question. This is where, with a show of hands. So this is a coronal section of the brain. So the coronal sections go in this direction through the hippocampus. So with a show of hands, is this a normal looking brain? 1, 2, 3, 4. Oh boy. You too. Does this show vascular disease? How many people think this shows vascular disease? A few more. How many people think that actually shows hippocampal atrophy? Okay. And I'll put a D down. How many people still don't know what this is? All right. At the end of all of this, you'll be able to answer these questions. Question number 2. This is an axial, so it's going in this particular direction, MRI section. So is this image consistent with, again, with a show of hands, A, how many people think this is Alzheimer's disease with this type of picture? How many people think it's B, frontotemporal dementia? Okay. And how many people think it's C, vascular dementia? And how many people still is a D? Not sure. Okay. This is question number 3. This is now an axial CT of the brain. So is this image consistent, again with a show of hands, A for Alzheimer's disease, B, vascular dementia, C, dementia with Lewy bodies? Okay. So keep those pictures in mind. They may just show up again. So let's just talk about CT versus MRI scan. So there's an advantage and disadvantage of using either a CT or an MRI. So what do you think? Just shout it out. How many people think, what's the advantage of getting a CT? It's quick. It's fast to get. Not only faster to obtain, it's a faster study overall. You can do a CT within 5 minutes. As opposed to an MRI, a good structural MRI, it's about 30 to 45 minutes. What's another advantage of a CT?
Less cost.
Yeah, up a couple $100 versus $1,500 for MR.
Better tolerated by patients.
Yeah, better tolerated by patients.
Less contraindications.
Pacemakers. What are disadvantages of getting a CT? It's radiation. What else would be a potential disadvantage? Sorry, Brett? Architecture, you don't get that much detail on a CT scan, especially the smaller structures. You may not get that resolution. What else would be a disadvantage of getting a CT? Contrast. For iodine contrast. Although MRI contrast for renal failure is actually not indicated, because you can get into bad side effects with that as well. So let's spin it around. What about MRI scan? What would be the advantage of getting an MRI?
More detailed information.
So detailed imaging. No radiation. What will be other reasons to get an MR? So you actually look at white matter disease a little bit more sensitive. The MR is a bit more sensitive for white matter disease. What would be disadvantages for getting an MRI scan?
Cost.
So cost is a big one. Time is another one. It's also very claustrophobic. I don't know how many people have actually been through an MR of the brain, but it's a very tight machine. Very tight machine. Not only you have a bore or the hole is about the width of your body, they put this plastic thing around your head. I've had 2 of them already, and for non-clinical reasons, where they would put this plastic thing over your head so that prevents you from moving side to side. It is very claustrophobic. You can't use it if someone has any metal in their body or any electronic device in their body, like a pacemaker or these electronic hearing aids. So there was a question asked to me before, how much radiation does a CT actually give you? So how much radiation in terms of, I don't know, number of chest x-rays do you think a CT will give you?
Several hundred.
So we got a 500, several hundred, oh, sorry? 300. Sounds like an auction. Anything on this side of the of the auditorium? So it's actually about 100 chest x-rays is one CT scan. And this is becoming a little bit more problematic. It's actually showing up more in our literature of the use of CTs and the amount of radiation someone is receiving. So what about their technique? So this is a nice picture. This actually shows the difference between identifying a CT versus an MRI of the brain. So 2 pictures, different patients, same level. So comparing a CT, how can you tell, just like looking at those pictures, a CT versus MR? What would be clues to help you recognize one from the other? So when you're looking at a CT, what's special about a CT? Sorry? The bone. So the skull on a CT is much thicker than what you see on an MRI scan. What about the quality? What about the fine detail? Yeah, so one's a grainy. So it's like an old black and white, well, my day, maybe Dr. Rockwood's day as well. The old black and white TVs, all grainy, right? So that's the type of resolution you're getting. MRI is more like DVD quality. That's the difference in terms of picture. So you can see the point doesn't work here. So very much, you can see very good subcortical structures, not on this one, on the MRI scan compared to the CT. So when you're looking at MRI, one of the most confusing parts about MRI is all these damn sequences that is reported. So you've got a T1, you've got a T2, you've got a flare, you've got a GRE. I think the key point to understand about all of this is what's the importance of all of them. I think that's much more clinically relevant. So T1 is very good at looking at structures. It's very good at looking at differentiating the gray matter, the cortex, or the subcortical gray structures like the basal ganglia or the thalamus. And remember that T1, the CSF, is always black. A T2 is very good at looking at water content. Once the CSF, edema from a tumor, edema from a stroke. Flare is actually my most favorite sequence because it gives you a little bit of both a T1 and a T2. So you get some structural detail on a flare. You've removed the extra T2 water signal out of it. So anything left over is considered abnormal. So whatever is bright white is therefore not supposed to be there. So I love flare sequences. It's usually the first thing I look at. GRE has an importance, especially in some of the work that we do, is that it's very good at looking at blood. Hemorrhages, old or new. So that's the importance of all of these sequences. So that's CT, it's MRI, those are the damn MRI sequences. Now, how do you describe the abnormalities that you would see on either a CT or an MRI? So when we're looking at CT, either items that you see are either hypertense, very bright white, or hypodense, a little bit on the darker towards the black region. On MRI, it's either going to be hyperintense, so now we're talking about density, we're now talking about intensity, so it's going to be bright, hypointense, a little bit darker, or isointense, equal to the gray matter. And each one has a significance. So on a hyperdense lesion on CT, it's typically blood, bone, calcium. Hypodense could be an acute infarct on a CT scan. And an MRI, it varies. And an MRI varies because it depends on what it looks like in all those sequences we talked about before. So if something's dark on T1, hypointense on T1, bright on T2, there could be a stroke, could be a tumor, it could be a cyst. While you can have hyperintense on both a T1 and a T2, it could be fat. Maybe it's a very acute or hyperacute blood. So it is the combination of the T1 and T2 and sometimes some other sequences that the radiologist requires, and I do go down to the radiologist to help me sort this out, to know that the lesion sitting in front of them is either a stroke or a tumor or whatever. So one of the things to look out for is this new technique, or relatively new technique, on MRI scan for DWI and ADC to pick up acute strokes. So this is a 43-year-old woman with acute onset right heavy paresis. She came into the emergency room, and this is her CT at presentation. Trust me, this CT is completely normal, even though you would suspect something on the left hemisphere. This is her MRI at time 0. And it shows a brightness on one image called the DWI and a darkness on the ADC. And that represents diffusion changes. So when you have a stroke, well, not you personally, but if some individual has a stroke, there's loss of energy. When there's loss of energy, the water molecules don't move around very much. So they'll stay there. And the MRI is sensitive enough to pick this up. And these changes are good for about 7 to 10 days. So if you suspect someone clinically having a stroke, you have that much time to get an MR. Because after that, all you see is the residual. It could be a big old black hole, it could be an old white matter spot on the FLAIR imaging, but you'll never know if it's an acute stroke or not. So that's the amount of time you have. Ideally, they should come in straight to the emergency room and get this all done within 24 hours. Because it took this woman 2 days to get the same picture on her CT scan. And that's a little dark spot where the other two white and dark spots are seen on the MRI scan. Anatomical planes. This is like Anatomy 101 all over again. And yes, it's going to come and haunt you, but it is very important to know the anatomical planes because there are certain anatomical planes you're going to focus on to look at certain structures of the brain. So an axial, very common. That's going in this direction. It's good at looking at all the lobes in the brain. Coronals, going in this particular direction, excellent looking at the hippocampi. It's actually one of the nicest ways to look at the hippocampi. It's very difficult to appreciate hippocampus through a sagittal view, very difficult. You get some better view on an axial, but I've been fooled on an axial, but the coronals are usually a fantastic way to look at hippocampi. Sagittal are very good at looking at midline structures, anything straight down the center. So an anatomical plane is very important. So that's the basics. So how do you tell the difference from a normal-looking brain or an atrophic brain? This took me days to figure out an analogy. So a normal brain is like a grape. It's big, it's plump, it's juicy. Over time, as the brain or the grape becomes atrophic or dried out, it looks more like a raisin. It's lots of grooves, it's smaller, it's shrunken down. If you don't believe me, there it is. This is a healthy looking brain on the left, and the person on the right is someone with advanced Alzheimer's disease. You could see that same analogy. That's a fat brain on the left, and it's all small, it's all shrunken down, it's atrophic on the right. So that's one thing you want to look out for when looking at either CT or an MRI when viewing dementia. The other one you got to look at is there any asymmetry? Now, if you can compare one side, the left versus right, are there any differences? And you can see here, there's a marked difference between the left side of the brain and the right side of the brain. The right side of the brain is actually a little bit smaller than the left side. So it's a left-right asymmetry. The other area you want to look at is it more in the front part of the brain or more in the back part of the brain? So anterior versus posterior. So this is where sagittal sections can handle you, or actually better is the axial section. So you can see here in the front part on the left where it says anterior posterior, that middle panel, it's actually the anterior temporal lobe, which actually is atrophic. We don't have a pointer. Laser? No, this disables the mouse part. The back part, in the last panel, the back part of the brain, parietal area, is the most atrophic area. So you can just compare the front and back sides. In fact, when I review images with patients and their families, I'll often use my pen either to demonstrate left versus right or anterior or posterior. I'll just put an arbitrary dividing line. One of the biggest difficulties when interpreting images is asymmetry, because you can overcall or undercall atrophy. So if anything that looks like the left panel, the right panel, looks like more of a Terminator type of picture, you can't interpret. It's like, look, he's got cataract on one eye and the other eye looks too big. If it is that term, you cannot make a distinction whether or not someone's atrophic or not. It's very difficult to do it. So the best way to see that everything is lined up is to look at the eyeballs. If the two eyeballs look roughly the same side to side, then it's more or less a very symmetrical plane of section. So that's looking at MRs, looking at CTs, and a strategy to approach them. But you still have to know some neuroanatomy and know what to look at. So I boiled it down to pretty much 5 things you need to know. One, you have to identify what the cortex is. It's that outer ribbon. You have to know what the white matter is anything below that. The lobes of the brain, whether that's a frontal lobe, temporal, parietal, or occipital. And you have to know what the hippocampus looks like. So this is the axial view. This is higher up. You won't see the hippocampus. When I lower down into in circle, it says TH with a big circle around, that's the hippocampus. So those are the key features that you really should be able to identify, because it's very, very common to look at over and over and over again. So any questions so far? It's all clear, like mud. So now we're going to go through the cases. So a couple of rules, again, just to reiterate what to look out for. So is it a CT that you're dealing with or an MRI scan? What plane are we talking about? Is it a coronal? Is it an axial? Is it a sagittal section? Are the images symmetrical or not? So you can make that determination. Is there atrophy? Yes or no? And where is it? So is it in front? Is it in the back? Is it the left or is it the right? Or is it all over? And is there anything else you see that I have not talked about? So here's where you guys go to work. Case 1, 57-year-old woman who presents with anterograde memory loss, problems balancing the book, getting lost in the neighborhood, burning food, forgetting how to use the microwave oven. So with that description, clinically, what do you guys think? It's Alzheimer's disease. So now looking at the picture, so that you come in. I think this person has Alzheimer's disease. So where should you be thinking of? Which in the brain would you look for? The hippocampus. Perfect. So looking at those pictures, first question, is this a CT or MRI scan? Sagittal, axial, or coronal? Axial. Is there atrophy? Where? I think we should pick on someone, come up and just point to it. It's not diffuse. It's a bit temporal, but where? It's temporal. Switch between sides. So this is actually kind of normal. This is it. This is the hippocampus. It's actually worse on the left than on the right side. To look at atrophy, you want to know how much space there is between the folds of the brain. That actually is a good rule of thumb. If you see a lot of space, it's probably very atrophic. If you don't see a lot of space, it's pretty much still plump like that grape. So that's the hippocampus. So on this side of the room, what we're looking at is here. That's the hippocampus. And you can notice it's a lot thinner. The normal appearance of a hippocampus should be like a big sausage, a big brat, equal all the way down. It's not supposed to look shrunken down like, I don't know, a burnt out brat on a barbecue. Here it is. I anticipated your question. So this is Alzheimer's disease. And in Alzheimer's disease, one of the earliest sites of predilection is the hippocampus, or the medial temporal lobe. So a normal hippocampus is equal. It's fat. Equal thickness all the way from anterior to posterior. As it becomes more atrophic through the disease process, it's typically the anterior and lateral aspect that shrinks out first. So this is the medial side. It'll start shrinking in this direction. And it'll all get smaller. And then typically you get parietal atrophy, then frontal, and then the whole brain will start to shrink after that. So this is the typical progression of Alzheimer's. You see the difference? Any questions about it?
Sometimes together reports that you have age-related atrophy, but how do you know for sure it's age-related or not? That the atrophy is appropriate for the age of the patient.
Well, I'm in the belief that there's no such thing as age-related atrophy. Two, I always look at the pictures themselves. I have to look at the pictures themselves. You know something that the radiologist doesn't know. You know the diagnosis. And the whole point of this is to look at the pictures yourself. If you're thinking, for example, of this individual having Alzheimer's disease, you're going to look at the hippocampus and see how big or how small they are. And I ignore everything else. Because depending on the radiologist, they may report it, they may not report it, but they sometimes don't have the clinical picture to discuss it. Or they may not have the expertise to know about it. So either you commented when ordering an MRI, is there hippocampal atrophy? But more likely enough, you should try to look at your own picture. Because that actually, you're the ultimate individual to report. Any other questions about this? So this is to give you a context of the progression of changes in the brain. So the left-hand panel, so this is the left here, that's a complete normal-looking brain. The arrows are showing what the hippocampi look like. Again, it looks like a brat. It's big, it's plump. The entire brain looks big and plump. And then the next several panels, year 1, year 6, year 7, is an individual with progressive Alzheimer's disease. And you can see the changes involved. Look at the hippocampus progressively getting smaller. And then you can see the rest of the brain following or shrinking after that. You can see the widening of the sulcus. Any questions with it? I mean, feel free to ask questions. And okay. So this is another case. This is a 54-year-old woman with anterograde memory loss, but preserved instrumental activities of daily function. So what is your clinical diagnosis? MCI, what subtype of MCI? Amnesic MCI. So that's your clinical diagnosis. So what are you going to look for on an MR or CT? You're going to still look at the hippocampus. So here we have the pictures. First question, CT or MRI scan? MRI. What section do we have? Or sections do we have? So we have an axial and a coronal. And what does it show? So is there an asymmetry? Is there a difference between the left and right side? Show of hands, how many people say yes? How many people say no? How many people don't know? Okay. Actually, there is an asymmetry. You have to look very closely at this. So this is the subtle stuff. I'll start at this side now. So we're looking here, right? We're looking at the hippocampus. If you look at this particular one versus this particular one, is there a difference between the two sides?
Right, it's smaller.
Yes, there is.
Yeah.
A little extra temporal horn of the lateral ventricle. This hippocampus is actually shrinking. What's this side? What's this plate? It's coronal. So on a coronal section, the hippocampus is here. So it looks like a big oval. Looks like an egg. There's the right one. There's a difference between the left and right side. The right hippocampus is smaller than the left one. So we'll look at where on this side. Here's the coronal nucleus. This little oval structure is the normal hippocampus. This one here is the abnormal hippocampus, which correlates with this structure. It's smaller in height and it's a bit short in width. So that's an early presentation of hippocampal atrophy in someone with a net thick NCI. So any questions with it? There's no mass. You can get volumetrics, but not every institution, even our UHN does not do that. None of these academic institutions do it because it depends on the person, actually, also. But it's visually, you could see the changes. Because we don't know what the normal hippocampal volume for one person. You can get groups of individuals, but not for one individual. Any other questions? So this is now another case. This is an 82-year-old gentleman with a previous history of strokes and slowly developing progressive cognitive and gait impairment. So clinically, what do you think is going on? Vascular. So vascular disease. So now you're going to look at the pictures. You can look at the images. So are we dealing with a CT or an MRI scan? CT. Axial, sagittal, or coronal? Axial. What do you find here? What you're seeing here? Asymmetry. There's a little bit of atrophy, but actually there's not a lot of atrophy. So we have some cortical changes, yes.
Periventricular change.
What kind of periventricular change?
White matter.
White. So this will be the hypodense. This is the ischemic white matter changes you see frequently on a CT, on a report. Or other things.
All strong.
Okay, thank you very much. So there are little hypodensities here. There's one there. There's another one there. Again, there's hypodensity there. There's a little one over there. Those are discrete infarcts. Yeah. And he's got a cortical infarct in the left parietal region as well. It comes all the way up to the cortex. That's this one here. Okay. So this is consistent with a vascular dementia process. Multiple infarcts, white matter disease on top of that. Any questions for this? This is another 75-year-old man with known hypertension, hyperlipidemia, type 2 diabetes mellitus, and suddenly develops apathy and memory loss. So again, what is your clinical suspicion? Stroke. So here's his, what is it, CT or MR? These are MRs. What are the coronal, axial? Axial. What sequence do you think these are? So let's go with this one here. Whoops. This one, the furthest left-hand panel. T1. It's not a T1. Why is it not a T1? Because you could see white on a T1. That can't be a T1 unless it's acute blood. So it's not that. Is it a flare? This is flare. It's like a T2 where you have the whiteness, but you've taken away the white or the CSF whiteness as well. So that's a flare image. So what do you see on that axial flare image? Right. So there's a lot of white matter changes around the ventricles. What else do you see? Well, he's had old strokes. He's got a big hole. There's a big hole right there. It's a previous stroke. What are the other 4 panels? MR or CT?
MR.
They're MR. What sequence? DWI and DDC. Remember, those are very good at picking up acute infarcts, and this individual has an acute infarct because of the sudden changes. So, and there it is. That's his acute stroke. There's a little darkness there. We actually had a thalamic one in here. That's the ADC map down there. So, on this side. So on the DWI, there's his acute stroke. There's another one, a little bright white spot in the thalamus, which I will give, it's the dominant thalamus, which will give him memory problems. And on the ADC map, it's dark, the little grid, but in the thalamus is a very, very dark thalamic spot with an acute infarct. So does this fit with your clinical picture? Yeah, yeah. So this is vascular dementia. So you can describe vascular dementia either in large stuff, macroangiopathy, or small vessel disease, microangiopathy. So you have the big strokes. These are the green arrows that I put down there. They'll be hypodense on a CT scan, or on an MRI, they'll look bright white. The microangiopathic disease are that ischemic white matter change that you'll see typically on a report. Also, remember I said there was one sequence on the MRI that was really good at blood. What was that sequence called? GRE sequences. Sometimes you will pick up individuals with microhemorrhages or strategically located hemorrhages, which the only modality to see it in, especially if it's old, is a GRE sequence. You may not even see it on a plain MR. Forget about a CT, especially if the blood has washed away. This is a person, I actually have another picture later, who has 2 very strategic microhemorrhages in the dominant thalamus. There's those dark layers where those arrows are pointing at too. The other aspect to look at GRE, if you have someone with Alzheimer's disease, and you have little dots all over the place, it could represent cerebral amyloid angiopathy. And that further enhances your diagnosis of the person sitting in front of you probably has Alzheimer's. Remember I said one of the advantages of MR is the detection of white matter disease. So I've got, this is the same patient, a CT and an MRI scan. And the MRI, this is the flare sequence on the MRI, that's the middle panel. If you look at the CT and MRI, can you tell there's a problem on the CT that there's white matter change? You have to look pretty close. Actually, they're very subtle hints, but it's actually very difficult to see. It just shows you the power of an MR to look at subcortical white matter change. And then the normal brain shouldn't have any change whatsoever. So that's Alzheimer's disease, amnestic MCI, vascular disease. So now we're in another case. This is a 64-year-old man who initially developed REM sleep behavior disorder, cognitive slowing, visual spatial stuff, visual hallucinations, and Parkinsonism.
DLB.
Yes, it's DLB. There's any reason not to think it's DLB. It's going to be DLB. So that's a clinical suspicion. Now you're going to look at the pictures. So is this a CT or MR? MR, and the sequence is? It's axial, but what's the sequence? It's flare. This is a flare sequence. Is there anything wrong with his brain? It's a bit asymmetrical. They're a little off. He's a little off in the scanner. Not by much, but a few degrees. That's why the ventricles look a little off here. Do you see anything that looks like a raisin? No, I'm not talking the whole brain, but what part of it? Actually, not really. This is a pretty good looking brain. I mean, you could argue maybe this is a bit atrophic, but actually it's on other sequences, on other cuts, it's actually fine. It's just the way this individual was lying down. This is essentially a normal looking brain. Yeah. I taught, huh? It's normal-ish. I should never have taught you. This is essentially a normal-looking brain. I'll get the other person instead. That MRI is better. So this is essentially normal-looking brain. So in Lewy body, individuals tend to have a normal-looking brain. There's very little atrophy associated with dementia with Lewy body. In fact, when you have a patient with dementia with Lewy bodies and you take a look at the brain, there's a whole bunch of atrophy. Chances are, in the publication that just came out last year, that you have a mixed pathology. You have mixed Alzheimer's disease and you have mixed Lewy body. So it's a nice clinical pearl to look at. And it actually tells you a response to cholinesterase inhibitor. If there's a lot of atrophy, you don't have that much response to cholinesterase inhibitor versus a typical or pure Lewy body patient. So that's the difference between them. Any questions about Lewy body? A 56-year-old woman who initially developed disinhibition, then hyperphagia, hypersexuality over the subsequent years. She died of a pneumonia at age 62. And I've got two panels here, one from 1999 and one from 2000. So first question is, CT or MR? It's MR. What sections do we have represented here? So we have axials. What else do we have? Coronals. What sequence? We have flare. This is all flare. So, are there changes on this MR? Okay, where are the changes? Frontal. What else do you see?
Asymmetry.
More right-sided. There's an asymmetry, left and right, front and back.
It's frontal.
Yep. So, what do you think is going on? What's your diagnosis?
FTD.
FTD. Behavioral variant FTD. Now, there's a little bit of white matter change here. Okay? In the frontal lobe. Right there, some white matter change. What do you think that represents?
White matter disease.
What do you mean by white matter disease? What kind?
Vascular.
So one possibility is vascular. What else could contribute to white matter change with this degree of atrophy?
Risk factors.
Well, that's stretching.
All risk factors.
The other part of it. Scoliosis. So you could overinterpret vascular disease if there's a lot of atrophy. So if you see such a focal area of atrophy, like we see in the frontal lobe, and there's white matter changes behind it, chances are it's not vascular. Chances are it's just scoliosis. It's a scarring because of the profound atrophy. So now this is a 54-year-old woman presenting with very profound apathy. This is the typical Uber couch potato. You will not move from their perch for any extended periods of time. And then develop disinhibition and language difficulties. So what is your clinical suspicion? So you have AD is one. FTD is another.
Semantic dementia. Semantic dementia.
Nope. Not with this presentation. Sorry? It's the presentation. So progressive aphasic will present typically with a language problem. In this case, it's the behavioral first and then followed by the language. So I tend not to call it one of the language disorders. So I think, how many people think it's AD? Show of hands. How many people think it's FTD? How many people? Not sure. Okay. This is actually the other presentation of behavioral variant FTD. So remember, behavioral variant FTD, you can have two clinical presentations. You can have the first case very disinhibited, very much in your face, doing all these wonderful, weird things in front of you. But then you have the other half of behavioral variant FTD who are very apathetic. And those individuals have a very specific area of the brain. Again, frontal lobe, but more in the singular, more in the midline structures. So here's an MR, and what does it show? What sequence is the MR? Flare. Okay, it's a flare sequence. So, is there atrophy on this MR?
Yes.
Yes, there is atrophy. Where's the atrophy? Front or back? Front. So frontal lobes, anterior. Is there any symmetry, left or right?
Less more.
It's a little bit more on the right than on the left. So there's a trick. If you're never sure, take a look at the ventricles, especially if it's a nice symmetric cut. If one ventricular system is slightly bigger than the other, the one that's bigger means that part of the brain is shrinking a lot faster than the other side. There's one way to look at it. So it's a bit more on the right than on the left, very frontal. Now, what about the second panel? What section is that? Those are sagittals. Remember what I said? What's the importance of having sagittal images? For midline structure. So here we're talking about someone with the apathy presentation of behavioral variant FTD, and I just said, the problem tends to be more here. So here I've blown out actually one of the pictures. What do you see there? The star kind of gives it away. Look at the entire sagittal section. If you look at this entire sagittal section, if you cut the brain right down there, this back part, parietal occipital lobe, is completely normal. The midline frontal is taking the bulk of the problem. So again, if you cut the brain right there, look at the back compared to the front. Very different. But not only that, look at, I've blown this here. This is your cingulate gyrus. And look how thin it becomes. It starts off normal, and then it's just tapering off to a point. That is the area for apathy for behavioral variant FTD. This is the other section of it. Yeah, and here it is. So there's your cingulate gyrus, and look how it thins down. And all fits. So this is what I just talked about. FTD. The behavioral, this is the disinhibition versus the apathy. So the disinhibition, it tends to be the orbitofrontal region. Remember Phineas Gage and that tube that shot off his head? That's where he went through. And then the apathy variant, which he went over. Any questions about behavioral presentation or behavioral variant of FTD? So how does it compare to Alzheimer's disease? So you tell me, there's a normal looking brain. These are all MRs, these are all axials, they're all flares. So the normal on the left, the middle panel is FTD, and Alzheimer's disease is on the right. What's the difference between the two? Yeah. So you look at the here versus here, the orbital frontal regions. It can be, but also we've seen a few cases where it's right more than left. But just look at where the shrinkage is. I mean, you remember going through medical school, there's that knife edge atrophy in FTD? Again, you just cut it down here. Cut it on that side. And again here, just cut it there. And that's how you can distinguish behavioral variant FTD versus Alzheimer's disease. The pictures themselves look very different. Now this is a 76-year-old woman who initially developed word-finding difficulties, fluent but slow speech, alexia, and acalculia. So what kind of clinical picture are you thinking about?
Primary progressive aphasia.
Which subtype? You asked. So you have three types of progressive aphasics. You have semantic dementia, you have the non-fluent progressive aphasics, and you have the logopenic variant. So of those three, which one do you think it is? So show of hands, so I'm not going to pick on any. Show of hands, how many people think this is semantic dementia? One. How many people think it's non-fluent primary progressive aphasia? Few more. How many people think it's logopenic progressive aphasia? Okay, so this is actually logopenic progressive aphasia.
Thank you.
And all the progressive aphasics will have word finding difficulties.
She's fluent.
But that's the thing, fluent, but logopenics tend to be more fluent than the non-fluents. If you're looking at a scale of fluency, if you had a spectrum of fluency, and you go from very fluent to the least fluent, the most fluent are the semantics. And it's very difficult early on in the disorder to think about, they actually have a language problem, until you hear them out for about 5 to 10 minutes, and you find out, I haven't heard a proper noun in 5 to 10 minutes. The logopenics struggle to get that noun, but they try to get it out anyways. While the non-fluents sound like a telegram. They're broken-like. And one of the very nice clinical pearls, when you do cognitive testing, because of where the site of pathology or the site of initiation of the logopenic is very close to the language, to the writing and math centers. So early acalculia, I'm thinking more logopenic. That's what the area is. So the clinical diagnosis here is logopenic progressive aphasia. Here are some scans. MR or CT?
MR.
MR. Sequence?
Flare.
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 What about the other two, the last two? The last two are T1s. And you can see there's a bit of a difference. It's a bit better structure on the sagittal, so it's a bit more T1. The flare is one of the issues if it's more black than or more black and white versus gray. The grays tend to be more T1s. Is there something wrong with this brain? Is there some atrophy going on?
Left temporal.
Left side.
Left
So
temporal.
left side, where left side?
It's not temporal.
Sorry? Temporal. If you compare, if you split the brain in half, compare this side to this side, and again split the brain in half, compare this side versus this side. Right. Here versus there. Is there a difference? Yes. That left superior temporal gyres into the parietal area is actually becoming atrophic. And if you look at the sagittal views, compare the left and right side, you can see how much of a change there is. And those two are equivalent sections. And that's where logopenic progressive aphasia actually originates from. And right next to that area is MAD, or in Gershwin syndrome. That's where you would look for. Now this is a 78-year-old woman who initially developed anoma with non-fluent speech, agrammatism, followed by disinhibited behavior 2 years later. So what's your diagnosis here? So it's a progressive aphasic. You have three types: semantic, non-fluent, logopenic. So show of hands, how many people think it's semantic? How many people think it's logopenic? How many people think it's non-fluent progressive aphasia? So this is non-fluent primary progressive aphasia. And the atrophy is here. Looking left and right. Always compare left and right sides. Oops. Again, there. Oops, sorry. There. That's where the area is. And you can see there's actually asymmetry. The ventricular system on the left side is actually much bigger than the right. Further telling me there's something wrong with that left hemisphere. So for the sake of time, this is a 53-year-old man with loss of memory for words. He loses their semantic knowledge. Try another progressive aphasic. This is semantic dementia. And this is a typical MR of a semantic dementia, where there is very profound focal atrophy, again looking left, right versus left, of the left anterior temporal lobe. That is classic of semantic dementia. There's nothing else, that, to my knowledge, in the literature that will reproduce this type of syndrome on MR. This is a 70-year-old gentleman who presents with initial inability to recognize friends, family members. So his initial presentation is a prosopagnosia, then followed by language difficulties. This is another variation of FTD. This is the right temporal variant of FTD. And if you look at this MR sequences, they're all axial flares. Do you see an asymmetry? The answer is yes. That right temporal lobe is wasted compared to the left. That's classic of right temporal variant FTD. So these are the temporal presentations of frontotemporal now. So the right anterior is prosopagnosia, left anterior is semantic dementia. And for the sake of time, we'll just skip all these. So I have some other slides. I can do it later. Looking at CT versus MR, there's a difference between CT and MRI scans. CT uses X-rays, MR uses magnets. The abnormalities versus in both. So in CTs, you're looking at densities, hyper or hypodense. In MRI scans, you look at intensities, hyper, iso, hypointense. And each one represents some pathology. The MRI sequences, the best sequence to use, I think, is still FLAIR. It's quick and dirty because the abnormality just shouts at you because it's bright light. It also gives you an idea of structure. GRE is very good for hemorrhages, ADC, PWI, acute strokes within the first 7 to 10 days. After that, all the changes disappears. Looking for atrophy. Remember, looking for the grade. The findings of the various dementias. In Alzheimer's disease or amnestic MCI, you're going to look predominantly at the medial hippocampus, or the medial temporal lobe or the hippocampus. In vascular cognitive impairment, you're looking for the ischemic white matter changes. Hypodense lesions on MR, hypodense on CTs, hyperintense on MRI FLAIR. The FTDs, talking about the behavioral variants, the frontal aspect, you're looking predominantly at frontal lobe atrophy. Disinhibition, orbital frontal region, sits right above the eyeballs. And the apathy, very much down the center. Then the temporal presentations, which are the language presentations. Semantic dementia, fluent speech, loss of semantic knowledge, left anterior temporal lobe atrophy. Right temporal variant, prosopagnosia as a presentation, and then non-fluent primary progressive aphasia. With non-fluent speech, agrammatism, it's the left insula. Remember those pictures I showed you before? Now you have all the answers for it. So this is a coronal MR. Is this, show of hands, is this a normal brain? Show of hands, how many people think this is normal? How many people think it shows vascular disease? How many think it's actually indicative of Alzheimer's? Better. There is right hippocampal atrophy here. Okay. right there. His right hippocampus is a bit smaller. So look for the space. There's an asymmetry between side to side. Question 2, axial MR. Is this, show of hands, Alzheimer's disease? Show of hands, how many people think it's frontal temporal? How many people think it's vascular? Right. CT of the brain, axial view. Show of hands, how many people think it's Alzheimer's disease? How many people think it's vascular? All right. That's it. That's all I have to say. Other questions?
I'm just curious if there's any usefulness in an FDG PET over, say, an MRI or a CT head? Or is that not really?
Depends on the situation.
Okay.
So I'm a little bit old school. I think that your clinical exam, cognitive testing, and MR is sufficient to make a diagnosis. And I rarely use FDG PET. One, because we can't get it clinically in this province. But if you're using it for, if you have a tracer with it, one day we finally get the amyloid imaging, yes, I think that will revolutionize our practice. But there is another indication to get FDG PET or a SPECT scan. If you have a structurally normal looking brain, if you've got that great looking brain, and you still suspect there's something wrong with this individual, that's where I'll get a functional scan. Because it'll highlight in picture ways the areas of deficiency. Now, one of the caveats of a functional MR, a functional scan, is that if you're going to ask the question, is this neurodegenerative or is this primary psychiatric, there's where you have a problem. Because a psychiatric disease like depression will also cause hyperperfusion or hypometabolism on a functional scan, because it mimics where that area of the brain is not functioning. So your indications have to be very clear. Any other questions? Great, thank you very much.